Welcome to this video on Cushing Syndrome, a condition resulting from chronic exposure to excess glucocorticoids. Key clinical features include moon phases, central obesity, muscle wasting in the limbs, abdominal striae, easy bruising, and metabolic disturbances like hypertension and hyperglycemia, often accompanied by a disrupted diurnal cortisol secretion pattern. Next, we examine hyperaldosteronism and congenital adrenal hyperplasia. Conn syndrome manifests through resistant hypertension and hypokalemia. Meanwhile, congenital adrenal hyperplasia, often caused by 21-hydroxylase deficiency, results in bilateral adrenal enlargement, virilization in females, and potential precocious puberty in males, driven by shunted precursor pathways. Pheochromocytomas are catecholamine-secreting neuroendocrine neoplasms. The classic clinical triad includes episodic headache, profuse diaphoresis, and tachycardia, often with hypertension and anxiety. Diagnosis is supported by elevated plasma-free metanephrines, while imaging helps localize the tumor. Other adrenal neoplasms include adenomas and carcinomas. This summary highlights adrenal hormone functions. The Zona Glomerulosa secretes aldosterone for salt and water balance. The Zona Fasciculata produces cortisol for glucose metabolism. The Zona Reticularis releases androgens, and the adrenal medulla secretes catecholamines. Remember the mnemonic salt-sugar sex for the cortical layers. We now transition from the stress-managing adrenal gland to the pineal gland. While the adrenal gland deals with rapid survival-oriented stress, the pineal gland acts as our chronobiological pacemaker, translating light information into melatonin to regulate circadian rhythms. The pineal gland, historically known as the third eye, is a small neuroendocrine organ located in the epithalamus. Lacking a blood-brain barrier, it releases hormones directly into the systemic circulation. It is attached to the posterior wall of the third ventricle and is essential for circadian and seasonal regulation. Embryologically, the pineal gland originates from neuroectoderm in the diencephalon roof. It is encapsulated by pia mater, with septa dividing the tissue into lobules. Its rich blood supply, derived from choroidal branches of the posterior cerebral artery, supports its high metabolic and endocrine activity. Histologically, the pineal gland contains pinealocytes, the primary secretory cells, and interstitial glial cells that provide structural support. We also observe corpora arenacea, or pineal sand, which are calcified concretions that serve as vital microscopic and radiological markers for the organ. Pinealocytes make up about 95% of the gland's population. They are large, irregular cells with active, euchromatic nuclei. Their long branching processes terminate near fenestrated capillaries to secrete melatonin, a process biochemically regulated by light signals relayed from the retina through the SCN. Interstitial glial cells represent about 5% of the population. These cells have smaller, elongated nuclei and resemble CNS astrocytes. They are distributed along connective tissue septa and perivascular spaces, providing structural scaffolding and maintaining the metabolic microenvironment. They are identified by GFAP staining. Pineal sand, or corpora arenacea, consists of basophilic, lamellated calcium phosphate deposits. This is a normal, age-related physiological process. Radiologically, these deposits are significant as a clear midline marker on non-contrast CT scans, allowing for the detection of potential mass effects or shifts. Melatonin synthesis involves a multi-step pathway, starting from L-tryptophan. Darkness stimulates the sympathetic pathway, which upregulates AANAT, the rate-limiting enzyme in this process, significantly increasing melatonin production. Conversely, light exposure rapidly suppresses this synthetic pathway. Melatonin is a master synchronizer. Its functions include regulating the sleep-wake cycle, modulating reproductive hormones like GnRH, and providing cellular protection through its antioxidant properties. It effectively integrates light cues from the environment to coordinate internal physiology, including immune and anti-aging processes. Clinically, pineal region pathologies include various tumor types such as pineocytomas or pineoblastomas. These can cause Paranau syndrome, characterized by upward gaze palsy, or hydrocephalus via obstruction of the aqueduct of Sylvius. Destruction of pineal tissue can also lead to precocious puberty and chronic circadian disruptions. This concludes our review of the adrenal and pineal glands. Understanding their anatomy, histology, and clinical implications is fundamental to pathology. Thank you for watching. This video provides a comparative overview of the adrenal and pineal glands. As shown in the table, they differ fundamentally in location, embryological origins, histological structure, and primary functions, with the adrenal glands managing acute stress and metabolism, while the pineal gland regulates circadian rhythms. Moving to a functional summary, the adrenal cortex and medulla are essential for metabolic adaptation and responding to stress. In contrast, the pineal gland acts as a neuroendocrine transducer, using melatonin to synchronize our systemic biology with environmental light-dark cycles. We also analyzed the distinct regulatory pathways for these glands. The adrenal axis relies on hormone feedback loops and hemodynamic sensors like RAAS, whereas the pineal gland is directly controlled by a neural circuit that responds to photic input received through the retina. Regarding clinical pathology, this slide summarizes common adrenal disorders like Cushing's and Addison's disease, alongside pineal gland pathologies such as pineocytomas and Cushing syndrome. These conditions often present with specific systemic symptoms related to hormonal excess, deficiency, or mass effects. To wrap up, remember the key identifiers: the GFR zonal architecture of the adrenal cortex and the presence of corpora arenacea for pineal gland conformation. This concludes our synthesized review of neuroendocrine structure and pathology.